Thank you, Cyril, for that overarching introduction. Now you put the pressure on me to deliver here. But it's been really exciting to be at this meeting where so many fields are converging. And I've been given a difficult task because typically I teach how to treat better diabetes to endocrinologists or primary care, never an audience where there's so many liver doctors. So this is perfect because over the years I became a gastroendocrinologist, and now I hope that the hepatologists are going to be hepatoendocrinologists moving forward and start prescribing these medications, because the problem is endocrinologists don't know that their patients have NASH, never treat them for NASH, and hepatologists say it's the endocrinologist's fault, they're not treating them. So today, I hope hepatologists are going to take the lead and break the cycles. These are my disclosures. And again, you've seen too many of these slides, but when we did this update with Norbert Stefan, what we wanted to highlight is that as you see more diabetes in darker red, obviously there's more NAFLD. And the real point here is that up to 1 in 5 people with type 2 diabetes have moderate to advanced fibrosis. So this is a large number, as this audience knows very well. Well, we talked to death about this relationship, but what I wanted to highlight is that the ADA also in 2019 realized that this is a problem. Before, it never mentioned NAFLD in their guidelines. And however, I think it's a very shy first step, as they rely on liver enzymes to begin doing a workup or in steatosis on any imaging to begin doing a workup for NASH or fibrosis. So I'll show you in the next slide why I think this is a problem. We have done assessments with using elastography, the CAP, and the BCTE from the FibroScan. And the numbers that I'm showing you are in 561 patients who came to endocrine clinics without knowing that they had diabetes, neither them nor the doctors. And you can see 7 out of 10 have NAFLD. That's why I think ultrasound is not needed, because most people already have it. But the prevalence of fibrosis took us a little bit by surprise. More importantly, liver enzymes are not elevated, so it's not a good strategy to use liver enzymes to fish these people out. I think this audience knows it. And about 15% had moderate to advanced fibrosis. Again, liver enzymes not very helpful. What we presented at this meeting actually was a little bit of a breakdown between endocrine clinics, internal medicine, and family medicine. And again, the rate of steatosis is about the same, because I think it's more driven by insulin resistance. But what we found really important to guide future therapy is that about 19% of people in endocrine clinics had F2 or greater, which is twice that in general medicine or family medicine. Or if you take F3, it was 11% compared to 3 and 6%. So for whatever reason, endocrinologists should be at the forefront of identifying this disease. The other thing is that we worked very hard with Scott Isaacs, who's the co-chair, and a group of very experienced endocrinologists in conjunction with the ASLD, and Dr. Rinella and Dr. Iannuzzi were the representatives who helped with this process to try to set up guidelines for endocrinologists. So we're very proud. Next Thursday, we'll be presenting them at San Diego. I can't tell you more because it's under embargo, but we hope that this will be really helpful for us as endocrinologists. Now, endocrinologists are really good at taking care of sugars, cardiovascular disease, well, good. We think we're really good, and nephropathy. And I always use this slide to tell them, remember the liver and the triad. Now, this time, I'm going to tell the hepatologist to remember the other two guys when you choose treatments, because I still see many times that that drugs that can help NAFLD are not prescribed. And I hope that at the end of this talk, some of the hepatologists in the audience are going to begin breaking that cycle. So I'll tell you how to do it. Now, the question that I always get, why, if we don't have any FDA approved for NASH? But diabetes drugs that we are using already for cardiovascular disease and for nephropathy help in NASH. And I hope to share with you some new data that has not been published, and old data that many people are unaware about these drugs. So let's go on to that. Before that, I mean, the diabetes strategy is not to reverse fibrosis. It's to turn off the steatohepatitis. So we wish we had a good antifibrotic drug. Since we don't know what the mechanisms are in fibrosis in humans, that's still a far out goal. But we can turn off steatohepatitis either with GLP-1 receptor agonists or with Pioglitazone. And the hope is that, and what the studies have shown is that significant amount of people, about half, have resolution of NASH, but fibrosis doesn't regress, and everybody gets turned off about that. But it does slow down the progression. So even if your people get frozen at F2, F3, or early cirrhosis, they're going to die of something else, most likely cardiovascular disease. Now, the real problem, as I see it, is with fat. So that's why, of course, all of this is an oversimplification. But I think a drug or an approach, pharmacological approach, will have to deal with lipotoxicity, with that sick fat. The ways to do it is either you lose weight by any means, and we heard another brilliant presentation by Naeem today, or you change the biology of that fat with a drug that paradoxically can increase fat because fat becomes more efficient and begins storing the excess energy in the subcutaneous tissue. Now, typically, what happens as a reflection of that is that adiponectin goes up 2 or 3-fold, which is a very good marker of healthy fat. And the other thing that I'm going to show you is the pioglitazone reduces visceral fat that we talked a little bit as a cardiovascular risk marker, and we think that that's why both drugs, GLP-1 and pioglitazone, reduce cardiovascular disease. So let's move on with this. So I tried to make it very simple. You know, obesity worsens everything. Worsens your insulin resistance, affects adipocyte function, high free fatty acids, low adiponectin. Weight loss will improve that. But again, what happens with weight loss is that it also improves diabetes and also improves your cardiometabolic risk. We heard that yesterday and today. What people don't know is that with PPAR gamma alpha or pan-PPARs like lanifibranor, you achieve the same effect, of course with some weight gain, but eventually benefiting NASH. And we'll talk about some strategies to mitigate that weight gain. So let's dive into your diabetes ABC. So at the end, you become diabetologist here, okay? So that is an old thing. Now, this is from last year. You have to memorize by the end of today the 240 gadgets that we have: insulin pens, continuous glucose monitors, insulin pumps. Now, that wouldn't be a problem, but also the pharmacological treatment is pretty complex. These are all the drugs that we have to treat diabetes: monotherapies, combinations of all of them with metformin, some with pioglitazone. That's a short list of insulins, but I see eyes rolling, and I understand why. I'm going to keep it very simple. So we have these old drugs, sulfonylureas, DPP-4s, the first one, sitagliptin, since 2008, easy drugs to use. We're going to divide the drugs in 3 classes. Insulin sensitizers, we're not going to talk about metformin. We love metformin, but it doesn't do a whole lot for NASH. We'll talk a little bit about new aspects of pioglitazone. We'll talk about GLP-1s and SGLT2. So you have to remember 3 things. Those 3 things, and you're done. So not going to talk about insulin. It reduces a little bit liver fat. We don't know what it does to the rest of the histology. So why are diabetes medications not used in NASH? So I see it on my beloved hepatologists. They never prescribe an oral agent, and it's just because they're not very familiar with them. I get the same answer. It's a diabetes drug. I'm a hepatologist. I send it to you guys. So the endocrinologist says they don't know that our patients have NASH, so I don't know which drugs help for NASH, so I'm just going to give them insulin. So, and there's also misperceptions in the middle of the side effects of GLP-1s and pioglitazone. I'll tell you a little bit about that in a moment. So all of you are aware, we were very proud to do that first proof of concept study. Dr. Belfort now is an associate professor in Yale. Then 2 studies in people without diabetes. You all know about Pivens. Then we did this 3-year study showing that the effect that you achieve at 6 months is about maxed out at that point, and the same over 3 years. And then we tried to harvest the benefits of vitamin E with all its controversies and pioglitazone, but the vitamin E doesn't add a whole lot. So, but the bottom line is that the results have been fairly consistent. Now, as you see, these studies have had 30 to 80 patients in PIVENS per arm. Again, they don't reverse fibrosis, but they will halt the progression of fibrosis. So that's something to keep in mind. They all go in the same direction. And that's why it was anticipated, for example, that lanifibranor will work. If you look at lanifibranor, the delta against placebo was 5% with the lower dose, 19% with the higher dose. With Pio, it's between 13 to 21%. And it's worked. Actually, it's the only NASH drug that has hit this dual endpoint of reversing NASH and reversing fibrosis. So there has to be something to this kind of approach. Now, the one way you can mitigate weight gain is starting with the low doses. So pioglitazone comes in 15, 30, and 45. Just start with 15 milligrams. The efficacy is pretty comparable to 30. 30 was the dose used, for example, in PIVENS. It has lipid beneficial changes, and the weight gain is 1 to 2%. So basically, you have somebody who's 70 kilos. If he does no diet, it will be 70.7 or 72. So that's something that is reasonable as monotherapy if you want to prevent NASH in half of those patients. There's a nice study that was published in Italy by the group of my friend Amalia Gastaldelli that compared 15, 30, and 45 in people with NASH. And in a nutshell, you see that the efficacy of the dose in reducing the ALTs is pretty comparable, also for GGT. And they measured liver fat and had an index of NASH. Nothing, earth-breaking, but it does give an idea that you can achieve some benefit with minimum weight gain. Now, we did another study with Amalia that we published in June, and what we learned from Pio, what it does, it gets fat out of the liver, reduces visceral fat, and puts the fat in the subcutaneous tissue. I would rather get rid of all fat, but what you do if you do lifestyle together with treatment. Now, what we wanted to understand, what are the mechanisms of action? And we did a statistician on Amalia's team examined by partial least square discriminant analysis, which were the factors, the many factors, and the factors that led to improvement in steatohepatitis and even some regression of fibrosis were high adiponectin levels. And actually, we did in our studies from annals, if your adiponectin triples within the first 3 months, you do better at the end. The other thing that predicted a histological benefit was reduction in visceral fat and, of course, improvement during the oral glucose tolerance test as an index of better glycemic control and less insulin resistance. But it's always good to see this. I mean, this is one of the patients in the study. On the left is before treatment. After treatment, you see visceral fat shrinking. You see an increase in subcutaneous fat, and of course, glycemic control improvement. I would rather have no weight gain, but this reduction in visceral fat can be one of the reasons why people on pioglitazone have a reduction in cardiovascular disease. So pioglitazone reverses all the risk factors that are associated with cardiovascular disease and NAFLD. I'm not going to go into detail. It even reduces the amount of fat in the myocardium and improves ejection fraction. So if I ask each of you before this, how many of you know that pioglitazone reduces cardiovascular disease in contrast to rosiglitazone? You wouldn't know, but the studies have been published. And it improves ejection fraction in people with type 2 diabetes, unless they have heart failure. So the first study, ProActive, also recruited people early on who had heart failure. And if you have edema and heart failure, you get in trouble. But otherwise, you don't. And I'm going to show you, these are all the studies that have been published since ProActive. None of them have had an increase in heart failure in these studies. So you can go to all these papers and look it up yourself. So just let me show you in a nutshell the effect of pioglitazone on major cardiovascular events. In that first study was reduced by 16%. And again, if you look at recurrent non-fatal stroke was reduced by 47%, and fatal and non-fatal MI by also 30%. This is old literature. People don't remember it, let's move on 15 years forward to the IRIS study. Here they took people without diabetes who had had a stroke or a TIA and gave them pioglitazone for an average of 4 or 5 years. Large study, 3,800 patients. And what happened was predictable. There was a 24% reduction in cardiovascular events. So this is very important because people still think of TZDs as rosiglitazone. Pioglitazone is a completely different molecule. And furthermore, in 2019, there was an analysis of those who took the tablets for more than 80% of the time. And again, you can see stroke MI reduced by 40%, 43%. Again, any combination showed a reduction. New onset diabetes was also reduced margin. So this is something important because our people with NASH have more cardiovascular disease. So how to use it? I always start with 15 milligrams. I avoid it if you're already very obese for obvious reasons. If they already have edema, that happens in 5 or 8% of the people. Long-standing diabetes or high doses of insulin is not a good combination. And if there's osteoporosis, because there's bone loss with the compound. And then you check on each visit, liver enzymes, A1C, there's any swelling, and so forth. Now, let's move on to GLP-1. So what do we need to know about that? I'd like to bring this is a recent review we just published, and to give credit to Dr. Patel, who's a fellow with me, finishing in a couple of months. Dr. Kayala is a young faculty. Basically, liraglutide has been studied quite extensively. All the studies show a reduction in liver fat. You know about the lean study. You know about Dr. Newsom's study. I'm not going to show you any of that. Just want to highlight one thing. What you're achieving is a slowing of progression. I don't think we need to aim or ask that 10 or 15%. This study was 12% weight loss is going to reverse fibrosis, maybe over time. But at least you're not going to have, as you can see with the highest dose, a much lower rate of progression, and I think that's very important. The other thing that many people don't know, that there's an oral version of semaglutide. I mean, as you can see, compared to placebo, there's a much better improvement in A1C. But even if you compare it to other diabetes medications, and you have there in the list sitagliptin, liraglutide, empagliflozin, another study with sitagliptin, it's also better. The drug has to be taken 30 minutes after breakfast. And I can get sometimes the insurance company to pay for that, but I know our Novo representative will fix that after the meeting. The last thing is, again, somebody mentioned reduction of cardiovascular disease is a target of our NASH patients for treatment. The one thing I want to highlight is that, well, there are two that in the United States we don't have anymore. But the one thing that's important, that even the oral semaglutide has showed a reduction of cardiovascular disease of the magnitude of the injectable. It's a much smaller study, so it's not significant. As you see, it touches the confidence interval there, but still probably with very good outcomes. The weight loss is about half of the injectable, the diabetes dose of the injectable. And finally, Naeem mentioned tirzepatide. Again, this has just been accepted, I think, 10 days ago. Dr. Gastaldelli is the first author in The Lancet. Again, large reductions in weight in the range in people without diabetes of about 15%, 12% in people with diabetes. And here you see a large reduction in liver fat, and percentage-wise up to 47%. And this drug is going for approval for the management of diabetes very, very soon for FDA approval. So how to use GLP-1 receptor? I'm going to start the lowest dose, then make sure the patient doesn't have gastroparesis or decompensated cirrhosis or gallbladder disease that is increased with these compounds. And then they can increase on their own at 4 weeks, and then you'll see them at the next visit and keep titrating up the dose. Again, it's difficult to give guidelines because there are several of them out there, but that's the general principle. And in general, if you hit a roadblock because the patient is not tolerated well, you can go down one step. And again, in 10-15% of people, you just have to discontinue. Insurance coverage is the greatest problem. Finally, in the last few minutes, I want to talk about SGLT2 inhibitors. Great drugs with a very apparently simple mechanism of action to lower glucose. You stop reabsorbing 90% of the glucose. Again, what was a little bit of surprise in the field that it would be so effective for heart failure and renal disease. In NAFLD, it's been tested quite a bit in uncontrolled studies in the top and about 5 controlled studies in the bottom. Some weight loss, reduction in liver enzymes if they're elevated, reduction in liver fat in all the studies. We don't know what it does to histology. And again, it's been used as a strategy to prevent weight gain with pioglitazone. If you combine, for example, in this study done now several years ago, empagliflozin to pioglitazone, you end up after a year and a half with net weight loss. So to finish, this audience should know that there are a number of side effects to it, like there could be DKA, rarely amputations. I think that happened in one study and not others. But GU infections and vaginal infections and balanitis is a real problem. So how to prescribe them? Just use the starting dose, and that probably achieves 80 or 100% of the dose, depending on the efficacy, depending on the agent. Again, if they have a history of recurrent urinary tract infections or yeast infections, avoid them. Be careful with older people because you can get them volume depleted, and then just manage with clinical criteria. So to finish, I hope that in this really very, very quick review of the diabetes medications, we can begin, taking action on our own. And the thing is, I put this slide, this is misplaced, but again, combination between semaglutide and pioglitazone has also been tried with net weight loss in the diabetes field, and most people achieving A1C without weight gain and without hypoglycemia. So this is my last slide. I knew Naeem would do a great job with the lifestyle intervention and bariatric surgery. Jorn did a great job yesterday. Again, remember that there are agents that can work. We don't have a very good answer on what to do with cirrhosis. None of these drugs have been really tested in trials. I have some anecdotal experience in early stage, but I think that there's a lot to do and a lot of awareness to be done to help our patients. So with that, thank you, and we'll talk about what the questions that you have.